Welcome to Medical Logistics 101. Today we will be reviewing head injuries, red flags not to miss. This video is for educational purposes only. It is not medical advice, does not replace a medical evaluation, and may not apply to your situation. If you have symptoms or concerns, please speak to a licensed healthcare professional. My goal is to help patients enter healthcare with a map instead of a blindfold, and to explain how clinicians think through these problems in resource-limited settings. Definitions. Head injuries scare people for good reason. Most are mild, but a small percentage had something dangerous underneath. Today I'm going to show you the difference, what's normal, what's not, and when a head injury crosses a line to something you should never ignore. Head injuries fall, for me, into two broad categories. The obvious ones that show symptoms right away, and the more subtle ones that don't show symptoms really into hours or even days later, and sometimes can be easily missed. Signs and symptoms that we associate with head injuries: headache, nausea, light and noise sensitivity, cognitive slowing, balance issues, irritability, emotional changes, and sometimes sleep disturbances. Exam findings: visible trauma, of course, lacerations, swelling, hematomas. There is sometimes a finding called raccoon eyes, where you have periorbital ecchymosis. That is bruising around one or both eyes that develops hours after injury. It is strongly associated with basilar skull fractures. Another one is battle sign, which is mastoid ecchymosis. It is bruising behind the ear over the mastoid bone, strongly associated with middle cranial fossa fractures. Cervical tenderness, of course. We always want to palpate the C-spine when patients arrive. If there's any history of fall, obviously immobilize the C-spine immediately. And if they're coming in by EMS, they almost always will be immobilized anyway if there's been a fall. Palpate the head, face, spine. Want to note extraocular movements with the eyes that can be affected by orbital fractures. I always like to have patients bring their teeth together and look for bite alignment, which will give me a clue about zygomatic arch fractures or other dental fractures. Exam findings: orientation, of course, person, place, time, situation. Speech: is their speech slurred? Is there delayed word finding difficulty? Cranial nerves: are the pupils equal, reactive, extraocular movements? Facial symmetry. Motor strength: weak, focal weakness, drift, asymmetry. Sensation: numbness, tingling, any asymmetry in their sensation. Coordination: finger to nose, rapid alternating movements, just part of my neurology exam. And of course, gait, unsteady gait, wide-based, unstable to walk. That one may not be something I can assess initially until I've ruled out other things like C-spine injuries, but it's definitely something I would want to assess before someone could be discharged home. Exam. One thing we look for is signs of elevated intracranial pressure. This can be worsening headache, vomiting, confusion or agitation, drowsiness or difficulty waking. In late findings with elevated intracranial pressure, you can have what's called Cushing's triad, which is elevated blood pressure, sometimes very elevated, bradycardia, and irregular respirations. Again, a late finding with a very elevated intracranial pressure. A differential diagnosis: concussion is a functional brain injury, no structural bleeding. It's a mild traumatic brain injury causing temporary changes in brain function, typically presenting with headache, nausea, fogginess, light noise sensitivity, and slowed thinking. Of course, we'll expect to have a normal head CT. Symptoms can last hours to days. Worsening symptoms require reassessment. So this is one of those that's very important to have a discussion of what they need to watch for at home. More serious issues with my differential diagnosis: brain bleeds, epidural hematoma. This is an arterial bleed involving the middle meningeal artery, classically associated with lucid interval with rapid decline. And the reason this is, the middle meningeal artery, if you look up the anatomy of that artery, it's literally plastered right up against the skull, roughly on the parietal area of your skull, just above your ear. This artery is, like I said, it's one of those things that's really right next to the skull. So if there's a fracture anywhere on that side of your head, and sometimes if it's an impact to the top of the head, much like if you took an egg and you tapped the top of it and had cracks develop down the side of the egg, that doesn't take much displacement of the skull to tear that artery in, because being an artery, of course, higher pressure than veins, the hematoma inside the skull will develop quickly and can produce symptoms. Literally, they're talking to you 1 minute and then rapidly lose consciousness. It's very, very dangerous and very deadly quickly. Subdural hematoma. This one's more common. Venous bleed associated with the bridging veins in the skull. If you look up the anatomy of the bridging veins, as we get older, our brains tend to atrophy, and that puts increased tension on those bridging veins that extend up the top of the brain. The common in elderly alcohol use, sometimes patients you'll see with that, as well as particularly anticoagulated patients, which of course is often in our elderly population too. This type of bleed can be very slow. Being venous, slowly accumulates. The patient may have had an injury several days ago. Now is having trouble with their gait, increased confusion, CT their head, and you see a subdural hematoma. Subarachnoid hemorrhage. This is the one associated with so-called thunderclap headache. Patients may tell you it's the worst headache of my life. Sudden onset, can be traumatic or aneurysmal. Diagnostic, CT of the head without contrast is our workhorse. The patient has to remain still with the head CT, any CT really, but particularly head CT, and that can be an issue with intoxicated patients or children. Sometimes, if it's really felt to be critical that you've got to have the head CT, that patient may require conscious sedation. One thing I would caution about that, if it's an intoxicated patient, particularly you don't know what things they have on board, whether it's alcohol or perhaps other medications, you're really going to have to monitor that patient's airway. And that's something to remember, that the CT scan is going to happen in radiology. So you've got to have close monitoring of that patient's airway if they're intoxicated, but you really feel you have to have the head CT. Again, close monitoring while you're doing that. I strongly consider CT of the facial bones and C-spine if it's trauma related. If the patient's had a fall, particularly if their mental status is impaired in any way, and I can't get a good C-spine exam, I'm going to CT the C-spine and generally going to CT the facial bones as well if it's any kind of trauma history. In labs, we typically will do if it's a stroke or head injury history. Pitfalls, assuming it's just a concussion with symptoms worsen. Missing brain bleeds in elderly anticoagulated patients. In full disclosure, if a patient presents and they give any history of anticoagulation, even an aspirin, daily aspirin, that person is going to get a head CT. It's just it just puts you in such a higher risk category if you're anticoagulated for atrial fib or any condition really. Underestimating low velocity falls in elderly patients. Again, go back to the issue of the bridging veins. And I'll make a little point about that. You don't necessarily have to have, in that patient population, you wouldn't necessarily have to have blunt trauma to the head itself. Say, for instance, an elderly patient who is a restrained driver, sudden onset and the head snaps forward, okay? That can be enough to tear those bridging veins. And again, the patient may initially not have a lot of symptoms just because it takes time. Being venous, it can take time for that blood to accumulate enough within the skull to produce the symptoms we associated with brain bleeds. Not discussing strict return precautions. This is a big one. You always need to discuss what they need to watch for. Those signs of elevated intracranial pressure, certainly vomiting. They need to be reevaluated if worsening headache for sure. Not obtaining a CT of the C-spine in osteoporotic patients. I generally will obtain a CT of the C-spine in any trauma patient where there's a head injury, but particularly with osteoporotic patients, of course, it's a systemic disease with osteoporosis. The amount of trauma they have to have a C-spine or any spine fracture can be surprisingly minor in these patients just because of the loss of bone density in their spine. Not evaluating for eye injuries in patients with edema around the orbits from trauma. Sometimes this is classically the Saturday night fist fight patient. A lot of edema around the orbits, may have trouble opening their eyes fully. And that can make it difficult to evaluate for injuries to the eye itself, such as puncture wounds to the eye or lacerations to the eye. The CT is helpful for us looking for orbital fractures and will give you an idea about whether or not there's major disruption of the eye itself. But again, it certainly is not going to evaluate for injuries to the cornea itself. Disposition, usually safe discharge if you have a normal neuro exam, no red flags, normal head CT, and you've got reliable follow-up. But again, I want to fully do a neuro assessment, more than one, while that patient's there before I would make the decision that they're safe to go home. Obviously, we transfer admit for any bleed, neurodeficits, or anticoagulant use if they're having symptoms or worsening condition. It's better to err on the side of safety with head injuries. If discharged home, you need to have that good discussion of symptoms to watch for and to return for reevaluation, including a change in their mental status or vomiting, symptoms of elevated intracranial pressure that I covered earlier. In closing, if this is the kind of content you find helpful, please like and subscribe. If there are topics you would like to see covered, you can email me at medicallogistics101@gmail.com. Remember, the danger isn't always what you know, but rather what you can't afford to miss. Thank you.